Stanley, I know this is not easy. So if there's any way you can indicate what you need and I can help, I'd like to do that.
Mr. Lee is a relatively young patient with end-stage kidney disease. He has recently suffered brain damage because of lack of oxygen.
A 33-year-old with an anoxic brain injury, status post-VFib arrest on the 12th of December.
The medical team believes Stanley is in a coma and will not recover, and they are struggling with how aggressive to be in his care.
His primary surrogate is his father. He lives at home with his parents prior to having this event, and they've been very clear on what they want, and that is aggressive care. Their belief is that he never talked about any advance directives, never made any decisions prior to coming into the hospital regarding not wanting to be resuscitated or not wanting to be maintained on life support. And also they are strong Christians and feel that God should decide that they shouldn't make any medical decisions.
I think it's one of the more interesting dilemmas we face. I use the word dilemma not pejoratively, but it really stalls discussion about limits on care, because what do you say when they say it's God's decision? I never have any success in doing anything but working with families to work through this, and usually the illness wins and not the clinicians. And
well, Stanley's father has decided to talk to Stanley about it, and that might seem silly to all of us because we don't really know what he can understand. I explained that to his father, but he does seem to nod yes or no to hurting and to some things. And I mean, what would be the ultimate best would be if Stanley could make his own decisions. Yes. And he's at a point where he can't, but maybe he can give his father some indications of what he wants.
What I wrote in my note yesterday is that we're going to walk a narrow line between fulfilling the family's wishes regarding aggressive care and not doing things that would be wasteful consumption of resources.
Also,
so
his comfort with his bottom
that means
broken down.
Diagnostic tests should be limited. Lab tests should be limited to what we absolutely need. The therapy should be tailored to the problems and to comfort. And if he deteriorates, then difficult discussions will have to ensue, because it would be wrong to perform cardiopulmonary resuscitation on this gentleman with severe anoxic encephalopathy. He's never going to be able to make his own healthcare decisions, and as much as they'd like him to, that's not a medical reality. So we can do our part to keep his care good, solid, comfort-based care, in keeping with the family's wishes and being supportive, but we don't have to go hog wild here, so to speak.
As far as being the caregiver, being a nurse, going into the room and having to, turn Stanley back and forth and see how his bottom is on fire. It's broken open, he grimaces, having to stick him for different IVs or different blood gases. Having to suction him is incredibly painful. He has spasms of coughing and he can't quite get up his secretions. And I sense from the healthcare team that they're really tired of having to put Stanley through all of this. It just, I mean, for what?
The medical team caring for Mr. Lee feel that he will not recover from his coma, and that the family should begin thinking about discontinuing mechanical life supports. An intern on the team has arranged to meet with Stanley's father.
And you know that, I mean, you've admitted the fact that you don't think he'll leave the hospital alive. I just want you to be aware of what might happen and what you'll have to see and what you'll have to go through as he survives mechanistically.